Now, our next speaker is Dr. Caroline McGonigle. She's a GP in Lifford Health Centre in Donegal. She studied in NUI in Galway, and she has completed a diploma in dermatology by Cardiff University and has just completed the professional cert in dermatology by UCD in 2020. And Caroline is here today to talk about rashes in the out-of-hours service, an enigma to us all. Caroline, thanks very much.
Hello everyone, and thank you so much for having me today to speak. I feel honoured to be presenting, and I also feel honoured to be presenting after Professor Luke O'Neill. So I suppose, as mentioned, my name is Caroline McGonigle and I am a GP and I work in Lifford. And Lifford is a little town which is on the border with Derry, and we're just across the bridge from Strabane. Now, a lot of you are going, gosh, Lifford, that little town sounds familiar, but for several weeks last year, we had the highest count of COVID per 100,000 in any electoral area in the whole country. So as a GP practice, we had to adapt quickly, and we went nearly completely to telephone triage. And thankfully, we're on the other end of that now, we're coming out of it. I think with all that in mind, I've developed such a huge respect for people who do telephone triage, because it really is a skill and it's an ever-evolving skill. So that's what I based a lot of my presentation on today. So I'm just going to share my screen, so just bear with me. So what I did sort of in preparation for this is I do a lot of work in our kind of out of hours, which is known as NIDOC, which is part of CareDoc. So I took a list of all the kind of the rashes that came into us. And I wanted to kind of go through it, because with this presentation, I know when you're faced with a telephone call, it's, are we going to manage this over the phone with over the counter? Does this patient need to come in to be seen by the doctor or whoever is on call? Or does this patient actually need to be referred directly to the emergency department? So what I'm going to do is I'm going to use this opportunity today to a bit of a teaching session, and hopefully by the end of this, you'll know which rashes to worry about and which rashes not to worry about. So I suppose the first thing, how we're going to break this down is we're going to go through descriptions. So describing a rash is probably the most important part. So I'm going to spend a little bit of time on that. Common things are common. So I'm going to go through all the common things that came in over kind of the few months that I was doing my call in preparation for this. When to worry, and then specific rashes for children, adults, pregnancy and elderly. And also I'm just going to give you 3 really good reference sites that I use a lot, and any of the information you get from there is top class. So this is the slide that I'm going to spend most of the time talking about, and it's description. And getting a good description of a rash or taking a good clinical history is 90% of the battle. And in most cases, you'll know from the description what exactly the rash is, and that'll help you then with your decision and narrow down your differential diagnosis. So when somebody calls me with a rash, usually it's mostly in the situation, it's usually mums and dads ringing in with rashes. I always let them describe it. And let them kind of give a few brief words about what's going on, and just to get a history from that. A few specific things I always ask about, and if you ask these things, you will get the diagnosis in the majority of situations. So onset, if somebody rings in and they've had a rash for months, it doesn't really need to be seen that day. You know, if you feel it needs to be seen, you know, it's all right to put it off to the GP the next day or the following Monday. If the rash has been there for months, it's not going to bother them too much. It's the ones that have presented maybe over hours and are getting worse, or even for a few days that are getting worse and mum and dad are concerned. Location is important as well, because the location of a rash can also give you a good idea of what's going on or what the potential cause might be. So say, for example, localize, so get them to describe where it is. So if a mum rings in with a baby and the rash is around the bum area, it's more than likely going to be probably some sort of napkin dermatitis. If a lady rings in and she's a rash under her breast or under her groin folds, it's probably going to be a fungal infection. But if somebody rings in and they've got a vesicular blistering rash and started on the face and it spread the whole way down, it probably is chicken pox. So widespread rashes, I do tend to kind of be a little bit more kind of worry a little bit more about them. The color is important as well. And there's 3 different colors that I always ask specifically about. So most rashes are red, but is it kind of like a fine red, or is it a really hot, angry looking red that might suggest infection? Is it purple? And what I mean by purple is kind of a purpuric rash. And that would be a kind of a red flag for me. And these people would need to be seen if they've got any sort of new onset purple rashes. Honeycomb crusting is something which you see in impetigo that we're going to talk about in a few minutes. And it's asking them if it's yellow and crusty. It might be there, but it might not be information that they might offer up. So it's always good to ask, is there any sort of yellow discoloration of the rash? And if it is, there's your diagnosis of impetigo. The size is also important. Small, new onset pinprick rashes, I would always worry about. Is it large? Areas of cellulitis tend to be large. So getting an idea of the size, again, will sort of help you. And I also ask about blistering, any sort of weeping, heat and itch. Blistering, there's not many rashes that blister, but they would, any sort of blistering, I would tend to kind of pay a little bit more attention to and probably see them that day or the next day. Weeping usually means some sort of evidence of infection. It may need to be seen even for dressing. Heat, again, would be a sign of infection. And itch is really good because really common itchy rashes would be things like chickenpox, urticaria. So if a rash is itchy, they need specific treatment for the itch and may need to be seen. Temperature and well-being. Temperature is important. Always document and ask about temperature. A rash with a temperature should raise red flags. General well-being as well is interesting because I frequently get phone calls, especially from mums, and they say, oh, my child has a rash. Okay, well, what are they doing at the moment? They're out playing on the swing or they're away off their summer camp. And that in itself would be kind of a good indication that it's probably not urgent and it can wait or can be managed with over-the-counter treatment. I always tend to ask about how they've been over the last, I always ask about 2 weeks. And you'll see kind of as we kind of move on through the different types of rash that we're going to discuss, that they might have a viral illness about 10 days ago and all of a sudden then they develop some sort of rash, and there can be an association between the two of them. So I always ask, God, how they've been, any illnesses, anybody unwell in the family, it's just as part of the history. I have this at the very end, blanching and non-blanching. We're going to talk a little bit more about this later on, but always do ask specifically if they're pinprick red or purpley rashes. Always get them to do the tumbler test. Takes 10 seconds and you potentially could save a life and make your diagnosis then and there on the spot. So as I mentioned at the forefront, I'm going to talk about different age groups because common things are common in different age groups. So with children, it's mostly the mum and dad who are ringing in, and sometimes it's the parents that you need to kind of reassure that everything is okay. And as I said, that's why you always ask about the child's well-being. Get a good description of the rash. And probably another reason to get a good description is whoever's reading then your notes the next morning. We frequently get NIDOC notes, and it also helps the person who is reading the description. If the patient is coming in, they'll have an idea of what it might be in. As I've mentioned, any preceding or concurrent illnesses, general well-being, and medications is important because they might have recently been on an antibiotic or just started an antibiotic for something or a new medication for an illness. And medication is a common cause of rashes or a new onset exanthem. Always safety net as well. I tell everybody, I'm a big fan of safety netting. If you're worried, if it gets worse, if it's not settling, just check in with your GP. So I suppose the first one that we would see, especially in children, it's common and thankfully very rarely causes any problems, is chickenpox. And the reason I started with this is because if you go through all the kind of the bullet points that I mentioned, is you could probably make this diagnosis over the phone. And I must say most parents actually know already what it is before they ring in. So it's a vesicular rash, so it's blistering. And as I mentioned, there's not many rashes that do blister, and they do tend to be on a little red base. So I think that's photographed below is a good indication of that. It usually starts on the face and scalp and then spreads quite rapidly. But I have seen children who just get 3 or 4 spots and that's it. And then you have other children then for various reasons, it becomes incredibly widespread. A couple of things with this is it can be very, very itchy. And they might need Phenergan, and Phenergan can't be bought over the counter. It's a prescription antihistamine and calamine lotion. A few things probably that I always kind of mention with this rash in particular is isolation advice because it is contagious, but also with pregnant. And I always ask if there's anybody pregnant in the house, and also maybe to let the teachers in the school know as well, because chicken and pregnancy can cause a few issues, but we won't go into that today. Along kind of with chickenpox, if you've made your diagnosis of chickenpox, a few things to ask about, and it comes back to the child's well-being. If this child is well, sitting down watching Netflix, eating and drinking, there's no problems, that's fine. But I always tend to ask about coughing, because a very rare side effect of this can be in pneumonitis. So if they're coughing, they probably might need to be seen. A very rare complication of chickenpox is group A strep superinfection. So I always have a very low threshold for children who have chickenpox. I always tell mum and dad to make sure that to keep an eye on it, that the crusts aren't getting overly red or weeping or oozing or developing a cellulitis, because they might develop this. And I must say I have a low threshold for prescribing antibiotics if I feel that any of these lesions are getting very infected. Oral involvement can be a problem as well. And I think this comes back to location as well. If they have any sort of ulcerations in their mouth, it won't be the chickenpox that will cause them any problem. It'll be the fact that they'll stop eating and drinking for you. So again, going back to your location and getting a good sort of description of where the rash is. Non-steroidals, I have this here because the advice is at the moment not to prescribe non-steroidals. Nurofen is a common go-to thing for parents, for children who have any temperatures, and of course you would go to it along with your paracetamol liquids. But I do tend to tell them to avoid this because there is a very rare side effect associated with this. So the next thing then is IMPETIGO. So again, good description. This is kind of a really red, moist looking rash, which is kind of in the perioral area, which is usually a common area to get it, in around the nose and in around the mouth. You can see it's got this yellow honeycomb crusting. So then, even from that description, you probably know it's IMPETIGO. There's two ways you can treat this. You can treat this with any sort of topical antibiotic, or they may need oral antibiotics. For this little child, you can see there's a few spots up beside the eye, so they probably will end up, and the extensive sort of nature of it will need an oral antibiotic. Again, going back to location, any sort of rashes around the eye as well, that's also an important thing to ask about, especially on facial rashes. Again, advice with this is just, it's highly contagious, but it usually it settles with an antibiotic either topically or orally, but it is contagious, and it tends to be kind of in the younger age groups. Slapped cheek disease or fist disease, this is really, really common, and usually parents will ring in and they will say, oh gosh, my child has been a bit off form for a few days, it has bright red cheeks, and all of a sudden then they develop this sort of rash. It's kind of like a really lace-like rash on their arms a few days later. It's usually when they develop the rash on the arm that they will ring in about it, because they all know the slapped cheek or the red cheeks and they don't tend to worry about it. Again, self-limiting, ask them, is the child well? Usually all these children are absolutely fine, might have a bit off form, might have a low-grade temperature, but they're usually fine and it'll pass by itself. Again, always ask about anybody pregnant in the house, and also if they're a school-going age, which is unusual because it does tend to be kind of the younger age groups, to let the teachers know, because it can have some effects in pregnancy, and sometimes women who are not immune to parvovirus do need kind of follow-up during their pregnancy. So urticaria. Urticaria is kind of common in children as well, and it looks more impressive than it actually is. It's really, really, really itchy red wheals, like they would be tearing the arms off themselves. But the classical thing about this is it tends to come and go over the space of a couple of hours. And urticaria, the very, very few, maybe one or two rashes that will come and go over the space of a couple of hours. So again, the parent will ring in and say, God, they had this really itchy rash on their leg a few hours ago and it's disappeared, and now it's kind of appeared in a different location. This is quite common after viral illnesses. So again, going back to, I had a patient recently who rang in about their 6-year-old and had really, really bad diarrhea about a week ago. All had settled, and all of a sudden then this started. So post-viral urticaria is very common, and it's self-limiting, and this child was very well. So over-the-counter antihistamines would be absolutely fine. But it is important to ask about other things that might raise kind of a little bit of suspicion or something else going on. Always ask about tongue, lip swelling, any sort of tummy pain, to make sure there's no kind of angioedema or significant allergy or anaphylaxis, because these children may need steroids, or even may need to go to the emergency department if it's incredibly widespread. So hand, foot and mouth is kind of a viral infection. Usually when parents ring in, they're just looking for confirmation, kind of isolation advice. So they get these little patches and blisters and kind of little lumps and bumps on their hand, feet and mouth. And again, these children are usually incredibly unwell, and it's a self-limiting virus. I must say, my oldest son is now 10, and some of the best photographs we have of him as a child, and he's smiling and happy, is when he has hand, foot and mouth. So they'll come out at his 18th birthday party. The next thing then is eczema. Eczema is a very common childhood condition, and it can get infected. And children with eczema do tend to get more widespread chickenpox and IMPETIGO. And usually the way this, and it's at a kind of higher risk of bacterial infection. So it's usually parents will ring in, they say, my child has eczema, but they have a patch and it's really red and it's weeping and it's itching. And the usual topical steroids or moisturizers aren't working. And so most of the time, these kids will either need a topical antibiotic or they may need an oral antibiotic if they have a temperature or if it's quite widespread. So this is the one that you don't want to miss. Non-blanching purpuric rashes are little pinprick purple rashes. So there can be lots of kind of causes for this. So again, if you go through and the parent says, yeah, there's small little purple rashes on the lower legs and the feet and it's just started, you know, there's a few things that will cause this, and we'll just briefly go through them, but all of them will need to be followed up in some way. So the first thing I always ask about is a temperature. And if they've got any sort of purpuric rash and a temperature, they're either going straight to the emergency department or straight into us, depending on which is closest. The second thing then is something called Henoch-Schloem purpura. It's an impressive sounding illness, but mostly children between the ages of 2 and 6 get this. And it's an autoimmune sort of little purple rash, which is caused because of a recent virus. And these children are usually well, but then mums and dads will kind of notice little purple rashes, and it's usually on the lower legs, and they'll ring in about it. These children are well, but they do need to be seen because you can get some complications, increased blood pressure, issues with their kidneys, so they do need to be seen. The next one then is thrombocytopenia, idiopathic thrombocytopenia. And then there's this with children then post-viral illness as well, just develop incredibly low platelets. And because their blood platelets are low, they develop bruising and little petechiae under the skin. So they would need to be seen. Leukemia as well is another one. And I had a child recently and mum rang in and said, God, she got a little unusual rash on the lower legs. And I was, how is the child? And she goes, I'm kind of worried about her because she was out in the swing today and she just fell asleep in the swing. And any child falling asleep on the swing is very unusual. So we brought them in, we saw them, we referred them over, and they turned out they had leukemia. So general well-being and the rash together is very important to ask about them. So the next cohort then are the adults, specifically the elderly or those who are immunocompromised. So these people present with completely different sets of rashes. And as I said, it's usually the children who will present or who phone the out of hours services the most. So drug history is important with this because this is the age group that will be starting new drugs or would be on several drugs. And also it's important to ask if they're immunocompromised as well. So shingles is something that patients do ring in about, and it's reactivation of the varicella zoster. And this usually presents what they'll say, oh, I've had a very kind of weird pain in my back for a few days, just kind of really burning, intense pain. And all of a sudden then these blisters came up. And that in itself can be kind of an indication or nearly a diagnosis of shingles. And shingles has a few characteristics. It tends to kind of just sit along the dermatomes. And I have a picture of the dermatomes there on the right-hand side of your screen. So it tends to be quite localized and it doesn't cross the midline. Usually it can, but it would be very unusual. And what I mean by the midline is it won't be on the right side of the body extending over to the left. It usually tends to be, I'd say, in the upper back right area or the left lower buttock region. Do these patients need to be seen? If they start their antivirals within 72 hours, that's absolutely fine. So if somebody rings in and they're an hour and a half away from the out of hours centre and they've got shingles, you're confident it's shingles and they're okay, you know, they can wait to go in and maybe get it confirmed with their GP in the morning and to start the antiviral. So you do have the 72 hours there. I would recommend that they do start some sort of analgesia because this can be incredibly painful even after the shingles rash has settled. Next thing then, we saw a kind of a burst of this recently, is scabies. And scabies presents, it's just as a result of little mites that burrow in onto the skin and cause those classical little burrows around the wrist area and the groin area. And it can be very, very, very itchy. If you're confident enough that this is the scabies, all the kind of the scabies treatment is available over the counter. So I would, you know, if they're happy enough to go and to collect that from the chemist and they can start it. But you have to advise, if it is scabies, that the whole family has to be treated for scabies. And usually it's somebody maybe who have been, say, staying in a strange bed or in a hotel room and or a bed that's different to their own. But it's important that the whole family is treated for scabies. Something to kind of keep an eye on is there is something that is quite similar to scabies that presents, and sometimes it can get a little bit mixed up, is something called pemphigus. And pemphigus is a type of eczema, and it presents like scabies because it's an intense, itchy kind of rash on the hands. But the thing with this, it comes with tiny little blisters, so they don't have the burrows. It doesn't usually affect it between the fingers, but they've got these classical little water blisters. And the reason it's important to maybe have this in the back of your mind is treatment is completely different. It's usually a course of Dermovate. For a couple of days. So light clear will probably aggravate it even more, but you need a little bit of Dermovate for it. So cellulitis, again, a really common thing that people ring in with. They'll ring in and they'll say, I got bitten by something, I had a recent injection for something, I have an ulcer, I fell, and now I've got this surrounding area of redness and heat. And that in itself would be indicative of cellulitis. So before we talk a little bit too much about actually cellulitis, there is kind of a rare type of cellulitis called erysipelas. And erysipelas is a type of cellulitis, but it's the top layers of the skin. So they tend to get very swollen, hot, red areas, but they can get blistering and areas of fluid and even necrosis. And this spreads incredibly rapidly, but these patients would be in a lot of pain. They would have a temperature, you know, they usually would ring within an hour or two of onset because it spreads quite rapidly. And these people need oral antibiotics as quickly as possible. And most of the time, these actually patients end up with IV antibiotics. So it's important to try and differentiate what's an erysipelas and what's a kind of a standard cellulitis. But usually with the erysipelas, it's really raised and swollen and blistering. Whereas ordinary cellulitis, because the infection is a little bit lower, it tends to be a little bit less red, and you won't get that blistering that you will get with erysipelas. But both of them are treated with oral antibiotics. And again, more common in diabetes and the elderly and the immunocompromised. So COVID rashes, I was so delighted to hear Professor O'Neill saying about 90% of us all vaccinated. I think that's an amazing achievement. So hopefully I'll be able to discard this slide moving forward in any future presentations. There's still a lot of work going on with this at the moment, but there has been a few rashes associated which actually present before COVID, while they have COVID, before and after they develop their symptoms. Probably the most common one is chilblains. Very rarely you would see chilblains, but there has been a lot of kind of case reports of chilblains associated with it. And again, other types of rash, like just general redness and purple rashes, the vasculitis that we've mentioned. I don't want to get too bogged down in it because hopefully it's not something that you will kind of see a lot of kind of moving forward, especially with our vaccination rates. But I just did want to mention that if somebody rings in and they are COVID positive, and they have a rash, it potentially might be associated with COVID because it is a viral illness. There was an interesting study done recently, and this is the biggest one I could find, of nearly 12,000 participants were COVID positive, and nearly 50% of them had some sort of rash at the time of their onset of their symptoms. And a few, 35% of these, their skin sort of rash developed after they developed their COVID. So one that I saw loads over the summer is Lyme's disease. And I suppose here in Donegal, we do have quite a lot of forestry and a lot of parks. And we do have pockets of areas where you potentially might pick up Lyme's disease. Now, Lyme's disease, again, I think the reason people are ringing in about it because there's a lot of information out there in the public domain about it, and especially over the last year or two. Lyme's disease is caused by a tick. Now, the important thing is the tick needs to be usually attached for up to 48 hours. So if the tick itself is infected and is attached to your patient for 36 to 48 hours, it is a possibility that they will develop Lyme's disease. Frequently, you get phone calls and the tick is only attached for maybe an hour or 2 hours. The chances of them developing Lyme's disease at that stage are quite minute. The reason this is here on a rashes chalk is because it has a real classical rash associated that can develop anywhere from 3 to 14 days after the tick bite. And it's known as a bull's eye lesion, or erythema migrans is the proper name for it. And what it is, it's just this lesion. It's got this red sort of periphery on it, a pale area, and then this big red target in the middle. And this would be a sign that they would need treatment. But it tends to be quite seasonal, and we would see a lot of patients maybe who are out camping in forests, or we have a lot of forestry workers as well, but it's always something to keep in the back of your mind, you know, because it is a quite specific rash, and any history of ticks as well, always just to be aware of it. So pregnancy as well, I'm always very wary of any pregnant women contacting the out-of-hours service, and I do take a lot of time with them. Any sort of itch, if any pregnant woman, especially in their second or third trimester, rings in with an itch, they really should be seen, because they may be developing kind of complications with their liver. Sometimes you can get during pregnancy. There are 2 specific rashes that women later on in pregnancy can develop, and they do need steroids and usually dermatological intervention. So if any pregnant woman rings in with a rash or an itch, do see them. Those 2 specific rashes that I mentioned, I have 2 pictures there on the slide, is PUP, where they get this sort of real itchy sort of plaque-like rash, usually on the lower abdomen and spreading up to their umbilicus and sometimes onto their limbs. And also pemphigoid gestational. So again, a vesicular rash. They'll describe blisters. So they definitely would need to be brought in to be seen. So we're coming to the end. So I suppose my gems of wisdom for any sort of telephone triage for rashes. In my experience, and I don't know, and I'm sure every centre is different, I often send patients, I will give them my WhatsApp number, and I'll get them to take a picture of the rash and send it in to me, because sometimes if you see it, you can make the diagnosis, or I'll do a video call with them. So I suppose things I always kind of ask, so if they're sick or high temperatures, they need reviewed. Any sort of children with rashes as well, again, it kind of comes back to the pregnant women, I would always review them. Sometimes you have to treat the parents. Sometimes the parents can be overly worried about rashes. So good communication, but isolation, over the counter, you know, any sort of contagious issues. So have a good chat to the parents. You know, eczema, parents with children with eczema, sometimes, you know, just going through the emollients and the steroids and what you can buy in the chemist. And that's all, sometimes the reassurance is all they need. I try to do as much over the counter or via the pharmacist as possible, because it's cheaper. I'm always very aware of writing prescriptions for people, because it can add up to 10 euros onto it. So I always advise them or encourage them to try it over the counter, because if it's cheap and it works and they can afford it, they will use it. Some of the creams and the lotions and potions can cost 20, 30, 50 euros, and patients are not going to continue that long term. And I'm always worried about the cost. So always think anything over the counter that we can do. And I always try that. I suppose we're kind of lucky here, being just near the border. There's a lot of things here that you need prescription for that you can get over the counter in Northern Ireland. Safety net, safety net, safety net. Even at this stage in my career, I always say, look, if there's any change, if it's getting worse, if there's any concerns, just kind of give me a ring back. And I know it's probably a little bit OTT, but they very rarely do if you've treated them properly and they know that they can ring back. I must say, I always say, if you're concerned, especially in the out-of-hours services, I will never say no to reviewing anybody that you feel is unwell or needs review, because these kind of rashes are usually quick consultations. As I mentioned, the minute you see it, you usually have a much better idea of what it is. So all I can do is speak for me personally, but I know for my colleagues as well, if you're unsure or you're worried, rashes in the out-of-hours is a very, very quick consultation. So I suppose these are my really wonderful references. DermNets, I have it on my desktop. It's the most fantastic, well-resourced sort of website for rashes, and it has everything there. Patient.co.uk as well is fantastic for any sort of patient information sheets, and this is more for like psoriasis and eczema, but even things for like IMPETIGO and scalp issues. It can be quite informative, and patients love things to read and to research. I've become very more and more giving patients websites because everybody Googles, everybody uses Dr. Google. So I'd rather them go to reputable sites than just go into Google and type in red rash growing area, because then they get all the horror stories. DermNeb is very good as well. So that's the end of my presentation. I hope you enjoyed it, and I hope you learned something from it, and I'm happy to take any questions that you may have.
Hello, Dr. Caroline, it's Geraldine here, and thank you so much for that. And that was very, very comprehensive, and it was fantastic that you had so much knowledge from the, the out of hours, and giving us all of that. Now, I have one question here, and it's to do with the ticks. we get a lot of patients phoning about ticks, which are only present for a few hours. Do they need treatment? Parents normally look for antibiotics due to the fear of Lyme disease.
Yes, I think this kind of comes back to what I've mentioned a few times is parents and reassurance. So if the tick is only present for a few hours, it's highly, highly unlikely that they will need treatment for it, because as I said, it needs to be attached for a significant amount of time. Also as well, it'd be just useful to see if Lyme's is endemic in your area. And there is a HSE website will actually show you maps of where there is kind of pockets and confirmed cases of Lyme's disease. So that's worthwhile, because if there's no Lyme's disease in the area, again, the chances of them having it are quite low. I suppose the other thing then is to educate them about looking for that target sign or the bullseye sign, which will develop a few days after. So just to kind of keep an eye on it. Again, if they are concerned, the treatment for it is doxycycline, and it's not an easy thing to take. So you have to weigh up the sort of the pros and cons of giving a course of doxycycline for several weeks to a child, and antimicrobial resistance. And I must say, I would probably reassurance in this case would be enough for this parent.
Great. Okay. Well, look, thank you so much for that. Okay.